sometimes to put it in the practice, we are always hesitating. And through these various every Tuesday webinars, we are just encouraging and enhancing the knowledge of our all IMS family members. And by doing this prescription writing webinar, I am sure that day by day we are improving our art of prescription. So won't waste much time. Today's topic is also very, very important, POI. And Dr. Sonia Madam, Dr. Jaideep, our guests are there. I think, thank you very much, Sonia Madam and Jaideep, for sparing your valuable time for us. I am again handing over to you, Shobha. So just let us listen from Sonia Madam.
I now request Dr. Ragini, the Secretary General of IMS, to say a few words. Welcome the guests of honor. We'll take the guests of honor messages one by one after this. Yes.
Thank you, Dr. Shobha. Very good evening to one and all respected seniors, our President, Dr. Anita ji, and all office bearer and dear friends. When we thought of having this prescription writing webinars, I'm thankful to Shobha to come forward and take it forward with the help of others. And we are having a very nice one by one, everything we are covering. And today's topic is a POI, that is a premature ovarian insufficiency, which is really increasing day in, day out. And here their problem is multifaceted because they're a younger population. Some of them not still married, not have a baby, or still a long sexual life is in front of them. So tackling their all aspect from the each point of view, it is very, very important. And I'm very happy to see that we have an endocrinologist with us, and no doubt we are very two big name in the field of infertility. Dr. Jaideep Malhotra and Dr. Sonia Malik, both are our past president, is there to share their knowledge. And I hope you are all really getting benefited with this program. And in the end, we will take a feedback, and if the feedback is good, we will like to have continue in some other way in future also with the in the next year under the leadership of Dr. Sudha also. So thank you so much, Dr. Shobha, and please start the academics. And
very well said, both Anita and Ragini. I think this year you have had the vision to create many more new platforms, and we are thankful to you for that. With that, we shall come to inviting the two most brilliant past presidents of IMS as guests of honor. And Ratnabali Chakravarti ma'am is a very senior gynecologist who has spearheaded this society for a very long time. Anita, can I request you to introduce ma'am and take her message, please? Can we have the CV of Ratnabali ma'am? I hope ma'am is here because I had given her a reminder. Anita, I'm not able to find ma'am actually.
I'll just call again.
Yeah.
I'll again call.
मैंने reminder दिया था ma'am को. Yeah. Ma'am, can we meanwhile go ahead by introducing Jaideep ma'am and taking her message, ma'am? Ragini, shall we do that? Okay.
Not able to, Shobha.
Yeah, even I was not able to connect. Please bring in Jaideep ma'am for her message. Dr. Anita, I request you.
Should I introduce, madam?
Yeah, please.
Okay,
please.
okay.
I thought it is only befitting that the president introduces the guest of honor.
Okay.
Yeah.
So we all know very well Dr. Jaideep Malhotra, madam. Jaideep is the director, ART Rainbow IVF Center. She was president of Indian Menopause Society also. She was president of Foxy also. And which organization is there where Jaideep is not there? So I'm not reading the whole CV, but Jaideep, who is the person who just start the Club 35 Plus. And I do remember when Jaideep just took over, I was the chairperson of Club 35 Plus, and she taught me a lot. And under her guidance, I also started Surat Club 35 Plus. And since that day, we are just rocking and encouraging each and every midlife woman. Whenever you are having any trouble, any issues, Jaideep is always there to help us. So Jaideep, very, very thanks. Thank you very much too for sparing your valuable time. I know you remain always very, very busy. You are someday in India, someday in Bangladesh, someday in Nepal. But thanks a lot for sparing your valuable time for us.
Thank you, Anita. I'm always there with you wherever I am. I am with all of you because my heart lies here.
Yeah.
A very good evening to all of you. And it's a pleasure to be amongst my fellow colleagues whom, I have cherished the company for many, many years. And I hope to do the same for the coming, whatever life I have. This is a topic which is very close to my heart because it's really important for us. Not only as an infertility specialist, we are seeing more and more of premature ovarian insufficiency and failure. But what is important here is that how to manage them, not only their reproductive life, but later even if they don't want to have children, still they need management. And that is something which we really have to understand. So, my heartiest congratulations to you all. You have taken up such a wonderful topic. And I am sure people who are going to attend this workshop are going to benefit immensely because there are so many doubts in our minds, when to start hormone replacement therapy or what to do, what are the implications of not giving it, what are the implications of giving it. Now these are really important areas which are a little gray sometimes, which need clarity. But what is important here for me at least to tell everyone is that this is one area where the prevalence of premature ovarian insufficiency in our country is much higher than the Western world. Now, that is something which we have to understand. Second important thing is that the long-term implications of POI, again, are very rampant, and we, especially our general practitioners and our OBGYNs, do not really understand the need of hormone replacement therapy in these people, which is, again, very important. Because if you're really looking at osteoporosis, we as it is have too much osteopenia. And if all of them who are, having insufficiency will land up into osteoporosis and a lot of fractures a little later in life, which will be much earlier than the rest of the population. Even the cardiovascular diseases and many other things which need to be really understood. And once we understand, we are definitely going to be able to, manage them well. So, and you have the best of the speakers here today. I'm absolutely delighted to, see the names, and I'm sure they're going to do justice. So all the best for all the deliberations for this workshop, and I'm looking forward to hearing all of you. Thank you for having me here. Thank you.
Thank you, Jaideep ma'am. Thanks a lot. And I have a special bond with Jaideep ma'am because when she was president of Foxy, I was president of my local society. And she handed over at AICOG Bengaluru her very, very successful presidential tenure. And I especially remember her tenure, Anita, for the number of public health interventions that she placed and the number of videos she made specifically for reproductive health and adolescent care. We are very grateful to you, ma'am, for giving so much vibrance to Foxy. And I still remember, I must mention Archana Verma's public awareness committee program, how that campaign flourished under your guidance. I will never forget that. Thank you so much for being here, ma'am, for inspiring us and for
And I
being.
say for Jaideep. Actually, when Jaideep was president, I was till now I am the secretary of public health of BOGS. BOGS, Bengal Obskyny Society, and in Jaideep's tenure, Bengal Obskyny Society achieved the best, the award for best public health
Correct.
society.
Correct.
Yes, and we went
Very,
to the
very inspiring persona. Very inspiring. Thank you, Jaideep, ma'am, for
Thank you
being
so much. Thank
and
you.
for your
Bless you.
messages. Thanks a lot. So now it is time to bring in the scientific session, and it is my pleasure to, and I have played it very safe today because I have the doyens in the subject to deliver the lectures. First, Dr. Mala Dharmalingam, a very close friend and a co-practitioner for several years, and of course, our very dear Sonia Malik, ma'am, who is that fountain of knowledge, that wealth of wisdom we have in her, so much that we want to listen to her today. So we will go ahead first with the invited speaker, the Dr. Mala Dharmalingam. Can I have her CV, please? So to bring Dr. Mala to all of you, she is a professor at, sorry, she was former professor and HOD at MS Ramaiah Medical College and Hospital, and right now she is heading the is director of the Department of Endocrine at Bangalore Endocrine and Diabetes Research Center. Very richly awarded for her work, a lot of publications, a fantastic orator, and a lot of chapters in books. I think that reading out all this will have less impact than listening to you, Dr. Mala. We want to give you the maximum time. So over to you for your lecture. The floor is all yours. Please share your presentation and
Sure.
carry on.
Thank you, Dr. Shobha, for the introduction, and a very good day to everyone. It's really a pleasure always to be amidst gynecologists. I'm just sharing my slides. Is my slides visible?
Yeah, absolutely. Yes.
Okay. So a very good afternoon to everyone once again. And today we are going to talk about primary ovarian insufficiency. And I did hear someone say that it is something which is very dear to them. It is also very dear to me because this is one of the conditions which actually will bring tears to one's eyes. So we are going to talk about the different, basically that it is a gonadal problem. We have elevated gonadotrophins. We'll also be looking at some of the symptoms, hormone deficiency, and a little bit at diagnosis and management. So basically, we're looking at hypogonadism. That means hormone levels are low. So this can be of two types. It can be pituitary, where we call it secondary or hypogonadotrophic hypogonadism. And then, of course, we have gonads, where we talk about primary or hypergonadotrophic hypogonadism. And today we are going to talk about hypergonadotrophic hypogonadism because that is what encompasses primary ovarian insufficiency because the gonads are involved. So basically, what is this primary ovarian insufficiency? It is defined as depletion or dysfunction of ovarian follicles before the age of 40. This leads to amenorrhea and hypoestrogenism. This is distinct from natural menopause, which of course we all know happens after 40. And here, intermittent function is possible in primary ovarian insufficiency. And even a very interesting thing is 5 to 10% may actually of primary ovarian insufficiency or POI may conceive spontaneously. There are many causes. We are talking about genetic, ovarian toxins. I'll just elaborate a little bit more. The causes can be genetic or chromosomal. The commonest we see is Turner syndrome and gonadal dysgenesis. It can also be iatrogenic because of chemotherapy, radiation, and pelvic surgery. And this is actually becoming very, very common nowadays. It can be autoimmune, ovarian or adrenal antibodies, and there could be a genetic mutation in the FMR1 pre-mutation, which we call Fragile X. And this is also very, very common. In fact, sometimes we miss it, but it's a common problem. And of course, idiopathic. So in chemotherapy, there are a lot of gonadotoxic risk, and this risk varies with age, agent, and dose. It could be alkalizing agents or procarbazine. These are the highest risk. If you irradiate the pelvis with more than 10 gyri, That's a major risk. And even if the periods resume, it does not mean that there is a total ovarian function resumption. So this fragile X, like I told you, is common. It's about 6% of POI patients have FMR1 premutation. 1% of carriers experience menopause less than 18 years of age. And this is exactly what I think some of you might have seen and found really difficult to understand, that why they have their hormonal disorders before 18 years. And testing indicated for unexplained elevated FSH less than 40 years or with some family history of a similar problem. So when can I say there is a primary ovarian insufficiency? There should be amenorrhea. Usually when we say menopause, we say 1 year, but here it is 3 months. FSH should be more than 30 in 2 different occasions, preferably a month apart. Of course, FSH should be taken fasting. Estradiol should be less than 50 picograms per ml, and you have to exclude pregnancy, thyroid disease, and hyperprolactinemia. So if it is confirmed, a karyotyping is a must. The FMR1 pre-mutation, if there are facilities to be done, should be done. Adrenal antibodies, pelvic ultrasound, and we can consider AMH as an ovarian reserve. It's usually very less. So I've just put all this down. I don't expect you all to read it, but just to understand that among the chromosomal abnormalities, you can see there's Turner, there's XXX, XPXQ deletion, X autosome translocation, gonadal dysgenesis, and then we have all of this, Prenal syndrome, progressive external ophthalmoplegia, and mitochondrial deletions, just to complete the list. And then we have premature aging also comes into this. Adrenal hyperplasia because of the STAR gene. And now after just enumerating, I will go case by case. I have 4 cases, and then we look at each one. And of course, at the end, if there are any questions, I'll be happy to answer. So the first case is Miss M. She was seen at 11 years. She's a known hypothyroid. She got hypothyroid when she was 6 years of age on 75 micrograms of thyroxine. She's well replaced. And the concerns of the parent is she's having short stature. On evaluation, she had stigmata of Turner syndrome. So this was their concern, that we have replaced hypothyroid and made it normal. So why is she not growing like other children? Usually we say, if thyroid you give, there's a catch-up growth and they will normalize. But she continued to stay short in spite of giving her thyroxine, and her TSH was completely normal. This is her growth chart. You can see she's well below the turn. There is a growth chart for Turner, which is called Turner growth chart. That is much less than normal individuals. She was short even in the Turner growth chart. So when we did an FSH, it came as 31.6. As you all know, it's quite high. And then when we did an ultrasound, they said there was no significant abnormality except small hypoplastic uterus, and both ovaries were visible but sort of smaller. And when we did the karyotype, you can see here, there is 46X. So here the importance is, if it is 46X, it is fine, but there's any evidence of a Y chromosome, it requires that the gonads may have to be removed because there is a small risk of it turning cancerous because of the Y chromosome being in the intraabdominal region. So this is what happened, and she turned out to be Turner. So in a Turner syndrome, you have short stature, and these are the different stigmata that we look at when we see a girl with short stature and primary amenorrhea. We look at all of these stigmata, whether it's low hairline, broad chest, droopy eyelids, low set ears, curvature of spine, widely spaced nipples, congenital heart disease, cubitus valgus, short fourth metacarpal, brown nevi, structural abnormalities of kidney, and some knee abnormalities also. So this is basically a SHOX gene abnormality. SHOX gene can be a problem in other disease apart from Turner, and there also they will present very similarly, though they may have a normal not a normal, but a chromosome type, which may be slightly different from a Turner. So this is some of the stigmata. And one should understand, also see as soon as the child is born, any of this lymphedema of the limbs, whether it is lower limb, upper limb, or torticollis coli, that is around the neck, that is what happens into webbed neck. You will see a child with lymphedema on the neck. As the child grows older, that becomes webbing of the neck. So these are stigmata which you can actually find out at birth, but not all children are born with such a problem. So we have to sort of carefully look at them. They're usually short throughout. So the other problem that we were all talking about was this bones. So a bone density is very, very important that it should be done, because many of the Turner's children will have a low bone mass, and you should also look for auditory function. Even they will have minimal hearing loss. And of course, this child had a minimal hearing loss, but they will have some sort of a sensory neural hearing loss. And also, very importantly, look at the heart, because there may be coarctation of aorta or bicuspid aortic valve or certain other cardiovascular problems. So these things have to be looked for in a Turner at baseline, and then again every 5 years if you're not finding this. So the child was diagnosed Turner, and she was appropriately treated. So let's come to the second case. This is a 25-year-old girl. She came for secondary amenorrhea. She was also a hypothyroid on thyroxine. She had attained menarche when she was 14 years of age, but by 19 years, it had become irregular and stopped by 20. From then, she was amenorrheic. She had irregularly taken HRT from certain doctors. And when we examined her, she had normal secondary sexual characters because she had entered puberty normally. However, on investigation, her FSH was 102 and LH was 32, and her estradiol was 8.6 picograms per mil. So when we looked at her scan, that was also hypoplastic uterus with small ovaries. And when we did her karyotype, however, the karyotype came normal, 46XX. So this can happen, and still it could be idiopathic, or this could even be a gonadal dysgenesis. But in gonadal dysgenesis, child will be very tall. This was not the case with her. She was average height, and she was not Turner, but had a similar kind of an FSH-LH picture. This child lady, we followed her up, and after 4 years of evaluation, her calcium, she complained of vague body aches. We know that hypogonadism may have bone loss. So we said, let's just do the calcium phosphorus. So if you see here, though, the calcium looks a little normal, but the phosphorus is low. It's just 2.6. This should trigger one to think, is it parathyroid? And also vitamin D deficiency can cause a phosphorus low, but her vitamin D was normal at 59.73 nanograms per ml. So with this value, we repeated, of course, and we found similar values. We did a parathyroid scan and saw she had a parathyroid adenoma. She was actually a psychologist, clinical psychologist. And then when we did the scan, this is showing a parathyroid adenoma, and for which she was operated, and she's doing well now. She's on replacement with hormones, and with her calcium came back to normal because just one of the parathyroids was involved. So once we removed, the other 3 parathyroids started working, and she was fine. So that she's the second. And now I'll take you into a third case, which is a primary amenorrhea, 24 years. Her height here, you can see, was tall. She was 170 centimeters. Her weight was about 45 kilos. She had no secondary sexual characters except a B2. She had B2 and no axillary hair or pubic hair. So when you see someone with no axillary or pubic hair, one should think of androgen insufficiency syndrome. Of course, the differential diagnosis was gonadal dysgenesis or androgen insufficiency syndrome. So when we did the scan, it came that uterus and ovaries not visualized, as you can see here. And so this diagnosis here was androgen insensitivity syndrome, which is a 46XY male with an androgen receptor defect. So the androgen is so much resistant that whatever is the testosterone, it doesn't work. So the secondary, right from birth. So there's no secondary sexual characters of a penile enlargement or any, or androgenic hair does not come. So why there is a little bit of breast development is testosterone is aromatized to estrogen, resulting in slight breast development. They look like very, very good looking girls. So the testis may be present in the inguinal region, or it could be cryptorchid, and there will be no axillary pubic hair, no penis, and no scrotum. They look totally like women, girls, and they will be brought up as girls also. There's no uterus and ovaries. So when we did a detailed examination for this girl, her testis was in the inguinal canal. Her testosterone was 650 nanograms per deciliter. MRI showed the presence of prostate and the gonads in the inguinal canal, and her karyotyping what was 46XY. So this was a case which presented like a primary ovarian failure, but an hypergonadotrophic hypogonadism, but was an androgen insensitivity syndrome. So this is my last case, which is she was a 39-year-old lady who was referred for secondary amenorrhea for 1 year. She also had a history of hypothyroid and thyroxine replacement, and now her symptoms were of perimenopausal symptoms. On physical examination, she was completely normal. And this was her FSHLH. As you can see, we thought she had a premature ovarian insufficiency, or early menopause, as we used to earlier call it. And when we looked at her ultrasound, it was reflecting what we thought. Her endometrial thickness was very less. So we thought she was into menopause. But on follow-up, she suddenly started developing darkness of skin and weakness. So we did a synactin stimulation test for cortisol, and we realized that her cortisol was not stimulable. So this fits into APS1, that is the polyglandular, autoimmune polyglandular syndrome. We used to call it APGS. Now it is called APS1. The commonest association in this is hypogonadism and cortisol deficiency. I did the test for men also, and also for APS, but both of them came negative, and she was APS1. So why this gonads and the adrenal axis is affected is because basically at the level of the pituitary, the stress signals are the ones which increase, and they both affect the ovarian receptor. Whether it's the gonadal axis or the adrenal axis, the final pathway is same, and the ovary has increased apoptosis of granulosa cells, ovarian cells, accelerated follicular activation, and they also have increased follicular atresia very fast. So that is why the adrenal gland and the ovary sort of go hand in hand for many of the hormone problems. So obviously, when we come to management, I won't go much into it because you're all experts, but basically replacing physiological estrogen to support the bone, the cardiovascular and sexual health. We usually prefer transdermal estradiol, 100 micrograms per day, or add cyclical estrogen 10 to 12 days per month for endometrial protection. OCs are not recommended because of they have very higher dose of estrogens. So this is again something I won't go through. But again, like all of us have discussed now, we have to think of fertility and contraception. We have to keep hope in the patient, saying spontaneous pregnancy is a possible. So what I usually do for a patient is I'll give them treatment for 6 months, and then I'll say stop it for some time. See if you start getting your regular cycles without medicines. And if they don't get, of course, we need to restart medicines. The type of contraception we usually advise for them is a barrier or IUD. But however, if you're not giving an estrogen contraception, you have to continue estrogen therapy like always. Comorbidities, very, very important. Bone loss. This is something, and that too, India has, I think, a lot of people with osteoporosis, somehow because of a calcium intake or a genetic milieu, we do have osteoporosis, and people with hypoestrogenemia definitely will have more osteopenia and osteoporosis. So monitoring BMD as indicated, and especially age-related BMD is required. Most of the bone densities are more than 20 years, but definitely certain centers do have them calibrated for adolescents also. Long-term cardiovascular, ischemic heart disease, so monitor blood pressure, monitor lipids, and 20% of all of the POIs can develop some endocrine problems, especially hypothyroidism. So it is recommended to test for thyroid at least once in 2 years or even annually if required. And if there is a facility to screen for adrenal antibodies, if they are positive, then it's a suggestion that this primary ovarian insufficiency is an autoimmune cause. Another very important aspect, like all of you know, is psychological aspect and counseling. It's very sensitive. I think, like I said, if there are two things that bring tears to my eyes, it is to counsel a person with POI, especially 18, 20 years, and then it is a type 1 diabetic. I think these two are the most difficult for us to counsel. And here, lots of impact on fertility, self-image. It's good to have a direct discussion with patient and family. But if the child is very small, I usually first discuss with the parents. And then when the child is a little bit capable of understanding it, then we call in the patient, the girl, and discuss with her, because otherwise she'll think it's the end of the world, and they may lead to a lot of problems, suicidal attempts and things like that. So it's very important how we tell the patient, to give them sort of I usually tell them to start studying well, work hard, become financially stable, and then possibly life will take on. And in today's world, everything is possible. So, and this psychological counseling sometimes may need a professional help. And from our side, we should use the term only insufficiency and not failure, because failure means that everything is over and done with, but that's not true. So it is insufficiency. Today, even a Turner child, even if she's not able to conceive naturally, we all know, many of you must have had Turners who you have helped to conceive. And I have had 2, 3 Turners who have done an IVF and conceived, delivered quite well. So I think the world out there is great. And today, unlike 20, 25 years back when people were told that, okay, there's nothing we can do, that's the end of the world, today there are a lot of options for them. So key counseling on explain on intermittent ovarian activity, fertility, annual follow-up, and encourage lifestyle for CV health, diet, exercise, avoiding smoking. So to conclude, premature ovarian insufficiency is a heterogeneous disorder, congenital, acquired, or idiopathic, common cause of infertility. Persistent amenorrhea, menopausal symptoms are the crux of hypergonadotrophic hypogonadism, and it's a straightforward diagnosis. However, establishing etiology is very challenging, especially because of the cost involved for the genetic testing. Many of them are not able to afford, especially when we tell them that's just going to help us just to get a diagnosis, but treatment will not change. So basically, they will say, okay, doctor, I'll think about it and come back. So what are the future directions? Improved patient education, awareness, giving them hope that all is going to be well. It is actually, whether it's their secondary sexual characters or sexual health, is going to be fine. It's only maybe a slight more help we need for conceiving. Bridging the gap between research and clinical care, very important. And we should be able to develop predictive or early diagnostic markers to indicate especially fragile eggs and such things, where we can have some indication, or autoimmunity, where we can say, okay, this patient may go, and what we can do about it. So thank you very much for a patient hearing. If there are any questions, I'll be happy to take them, and I'm stopping to share.
It's a wonderful presentation. Yeah, very nice.
Thank
And
you.
I think we briefly went into primary amenorrhea, and then we came back into primary ovarian insufficiency. But yes, you did bring the entire heterogeneous picture into the fold today. And thank you very much for that, Mala. Any questions from
So
anyone?
Mala, what I can say as a gynecologist, literally we have got some different insight in your talk. So
Okay.
thank you, Shobha, for inviting Dr. Mala.
Yeah.
And I think we should have this interdisciplinary discussion that give us a more something new in every time when we listen. Thank you so much for such a crisp, clear,
Yeah.
and very
I
concise presentation.
Thank
Yeah,
you.
same from me also, Shobha. Thank you
thank you,
very much
Anita.
for bringing Mala to this
Yes, yes.
webinar. And thank you very much, dear Dr. Mala. It was wonderful presentation
Yeah.
and very, very informative. You made all the doubts very clear.
Yeah.
Thank you.
I think Sonia ma'am has also commented simple, excellent talk. I think Mala took a lot of efforts to make it very simple. She took efforts to make it. Ma'am, आप muted है ma'am.
She must have thinking we are sitting in front of her, no? To make it easy for us.
Yeah, but it came out
Nice.
lovely. I just wanted to know, Mala, whether the genetic testing that you mentioned, you said that the management is going to be same. It is good to know that, but I also wanted to know if the prognosis is the same. Suppose the genetic markers are there, the mutation, as you mentioned, is there. Is the prognosis a little different?
Maybe, see, autoimmunity has a highest chance of becoming normal. The autoimmune
Will be
premature ovarian
self-limiting.
insufficiency. Yeah, they have this spontaneous. In fact, I had one patient, and I had told, I thought she was primary ovarian insufficiency. This was way back in, I think, 20 years back. And then Dr. Jaya called me and she said, Mala, your patient has become pregnant. I think me and Dr. Jaya were more happy than the patient. It is so good when you think that she won't conceive. No, she was married, and her FSH was high, LH was high, and I actually thought she won't conceive, but she conceived. So those are the small joys that we have. But
Mm,
yes, like you said, this antibody autoimmune is Fragile X and Turner almost they don't, of course, they don't improve, but autoimmune ovarian failure does improve. But to
mm,
do these antibodies and all are very difficult. They don't do it even in the genetic testing. We have MedGenome here who does
mm.
genetic testing.
Medgenome does a good job.
Yeah,
But
they
have
do.
you found any help in these cases?
Yes, I have found sometimes they are helpful, especially in APGS. I have found patients
BPGs.
having this fragile X and all. I have not found actually, though I assume that sometimes looking at the thing they must be fragile X. But the simple XX, the karyotyping that we normally do,
Karyotype, yes.
that is to a large extent beneficial. But yes, if we are suspecting autoimmune, if there's especially if there's an associated thyroid or something, you have to think it's autoimmune. There to do adrenal antibodies is definitely useful.
Yeah, see, immunological testing, not that great a problem we face. It is the genetic testing which we
True,
find very,
true,
very
true,
difficult because
true.
they are very exorbitantly expensive.
Yes, true,
But I also thought that it will be good to give a message that even though expensive, if the parents or the family can
exactly.
afford, I
Yes,
think it is worthwhile because how long can we be saying, our population cannot afford and not document our scientific
true,
data, right? We must have the material that we get somewhere documented, and we must have an account of these things. So
true,
I think we must encourage them to test,
true.
and if not possible, then so be it.
Yeah,
Thank
like
you,
you said,
Mala.
Dr.
Many
Shobha, it's very important. At least 20% of people are now testing, though they are 40,
That's
50,000 tests.
that kind
There's
of
people to
understanding.
test.
Very
Yes,
good.
yes.
Very good.
Shiva, many time we doctor take decision for them that
Hmm,
they cannot afford.
Yes,
We
exactly.
should
correct,
That is
not
correct.
also
write
true.
यही
unnecessary
मेरा कहने
treatment.
का मतलब यही था रागिनी.
Yes,
Unnecessary treatment we should not write, but where it is required, we should counsel
absolutely.
them and leave on them whether they can go for those tests. And 50% will go for those tests.
Correct.
Agreed. Very, very well put. I have just one more question before we go on with Madam. Uh, have you found mosaic Turner in your practice? Because
Plenty of mosaics are there.
Of
That
mosaic.
is why karyotyping is so important. And again, in mosaics, there is a chance of conception and cycles are happening. So
so
definitely,
is mosaic Turner much more common than Turner?
actually, I've not looked at that data in
Okay,
specific,
fine.
maybe equally common. I won't say
Okay,
more common,
fine.
equally common.
Okay, but they're difficult to pick up because they're not classical. So
Ah,
yeah,
sure.
thank you so much,
Okay,
ma'am.
thank you so much. It was really a pleasure.
Yes.
I'll
Thank
take
thank
leave. I have
you,
another
Mala.
meeting happening. So
Yeah.
thank you very much. Okay.
Thank you very much.
Sure, sure.
Yeah.
Thank you, Mala. Thanks a
Yeah,
lot.
thanks a lot. Yeah.
Lovely hearing you. Lovely.
Thank you. Bye.
Ragini, can I request you to introduce
I think
Sonia
it's all
ma'am?
right.
Will
It's
you
all,
introduce? Yeah.
it's all right.
Why not?
Why
I
not?
can introduce her by closing my eye. I don't
That's right. That's
want
right.
to read her this whatever written, because whatever written is just a written thing. What she is, she's beyond this. As for me, I've never met any more person who is more adorable, more approachable, more intelligent, and more compassionate than her.
Thank you.
And in Haryana, we all vouch for the Sonia Di, not the Sonia Madam. And as far as her understanding for the things deep inside in the new problems goes, it's marvelous. So all these things will come automatically for her. So I will not speak much. If I will start to speak instead of you, I am going giving the lecture. Welcome, Sonia.
Thank you.
No,
Thank you.
but ma'am
Thank you
is
very much. Thank you.
director and HOD Nova and past
ये वो
president
तो
Indian
सबको मालूम है,
Fertility
किसको नहीं मालूम है, छोड़ो.
इसको नहीं मालूम है अच्छा
तो
छोड़ो
लिखा है ना, पढ़ लेंगे अपने आप.
Thank you so much. Thank you.
One word from me also, Shobha.
जी
Yes, of course.
Sonia Madam is just my mentor. When I started Surat chapter of Indian Menopause Society, Sonia Madam was secretary and Dr. Asha Kapadia Madam was president.
Yes,
And I was so much eager to bring Madam to Surat for my installation. But
Which is
somehow Madam couldn't, Madam was busy and she just told that Asha Kapadia Madam will come and she is also so humble. So you just enjoy with her. Since that day, Madam is just my mentor. Any problem, any question, Madam is always there. So thank you, Sonia Madam.
Thank you, Anita.
एक
You
लाइन मेरी और, एक लाइन मेरी और, मैडम के हम्बलनेस पे. एक बार मेरे एक प्रोग्राम में ना चीफ गेस्ट ने धोखा दे दिया, वो वही स्पीकर भी था. अब क्या करें?
Hello.
मैं इनके पास गई, मैंने कहा देखो सोनिया जी, अब इज्जत का सवाल है, अब सब कुछ कैंसिल करो और आ जाओ. नाम किसी और का लिखा है लेकिन आपको आना है. एंड शी केम फॉर द टॉक ऑल्सो द
Great.
लास्ट मोमेंट. थैंक यू सो मच.
great great
Thank you, thank you, thank you. वैसे मुझे याद नहीं है ये जो तूने कहा है. मन से बना लिया, अब कोई बात नहीं, चलेगा. ठीक है. Thank you so much. Thank you, thank you. Thank you. It has been so enjoyable being with all of you all these years.
thank you
That is so interesting, such a good feeling, and a feeling of living within a family. That is the biggest beauty of this society and all of us over here. You know, this, and more than that, this COVID has brought us very close, because basically we have been able to reach out to each other like this, and we don't seem to be missing each other because we can talk and we can see each other. So thank you very much for having me here and thinking of me all the time. And Shobha has literally dragged me here this time, trying to tell me that I have to do something. So let's see what I can do and justify what she's told me to.
Thank you.
Because Mala gave a beautiful talk. It was very simple and beautifully put. I don't know what I'm going to do, but anyway, let me try. So can I share my screen now?
please ma'am please
Okay, here it is. Okay. Yeah, so I think you can see my screen now, isn't it? You can see my screen, all of you? Is my screen?
yeah we can see
Yeah.
yeah
So essentially, I was asked to explore the fertility option for these women of POI. And I will start by saying that, you know, ovary is one organ that dies when the woman is still alive. You know, so this is one organ in the body that actually faces death. And this is normal. This is what we are today, the Indian Menopause Society, which signifies the death of this organ. And therefore, we must always understand that ovarian aging is actually the pacemaker of the female body aging. And actually drives the aging of multiple organs in the body. And this is what is the primary statement that all of us must remember when we are trying to think about the ovary. So, falling ovarian reserve has become a topic of the day, and I would say the century now in the coming years, We are all going to talk more about diminishing ovarian reserve rather than anything else. Even the sperms have started to diminish. So therefore, fertility seems to be hit very badly. And hence, we have to be very, very vigilant and start thinking about how to do something about it. India is also shrinking in its families. And we all know that the TFR is falling to 2.1 now. And they say that it is the education of the women that is at play, because if we have uneducated women, the TFR is still high. And if we have educated girls, they think about having small families because they want to give their children a good life. So therefore, basically the global fertility rate is declining, and so is ours. And there are various causes of declining fertility rates. Why I have put all this here is because it does relate to what we are going to talk about, premature ovarian aging or insufficiency. In the urban areas, it is the lifestyle factors such as smoking, excessive alcohol taking, intake, drugs, obesity, environmental pollution, pollutants, and toxins which affect the fertility. And in the rural areas, we mustn't forget it is as bad as it is in the urban setting, and it is because of the fertilizers, pesticides, but most importantly, genital infections such as tuberculosis and others as well as smoking in the rural belts also. So menopause occurs 5 years in advance of the Caucasians. This is a fact which has been proven many times by many studies in India, and for us, most importantly, is the one that Maninder conducted. So it occurs 5 years in advance of the Caucasians, and this is something that we must remember whenever we have a woman coming to us complaining of features which might suggest that she is having some kind of a perimenopausal problem. So premature ovarian insufficiency, as Mala had already described, is a clinical syndrome which is defined by the loss of ovarian activity. And according to the ASHRAE guidelines 2025, the POI in the FSH must be 25 and above for 2 times. And if it is failure, then it has to be 40 IU per liter more than 2 times. But of course, we also have the clinical features that should be some kind of a menstrual disturbances. So both of these put together, they constitute premature ovarian insufficiency. So causes, of course, I have elaborated already to you that there are urban causes as well as rural causes. But what happened is that it was in the year 2011 that people started taking a little bit of this problem seriously, and they thought that we must have some kind of a guideline in order to help us define these patients where they were coming to us for failed fertility. This was not at that time considered something where menopause is going to affect them all their life, but basically the issue was that of failing fertility. And hence, they said that if out of these three features, that is advanced maternal age, less than 40, or any other risk factor, previous POR, which means that poor ovarian reserve with less than 3 oocytes, and an abnormal ovarian reserve test. If any of these two of these three were present, then patient will actually be labeled as having premature ovarian insufficiency. However, it was later on when they found that this was not sufficient to describe the kind of patients that we were getting. It was in the year 2016 that this group actually gave us a kind of a categorization or stratification of these patients, which is called the Poseidon groups. And we have 4 groups based upon their clinical features, which actually described what was happening to these women. So the groups were divided according to the age, less than 35 and above 35. And group 1 and 2 actually were the ones which showed nearly normal features of, the ovarian reserve tests were normal, yet they were showing insufficiency. And these were labeled as unexpected poor ovarian reserve patients or poor ovarian insufficiency. In group 3 and 4, these were patients, again, younger ones, less than 35 fell in group 3, and more than 35 were group 4, and both of them actually showed features of insufficiency. Hence, they were known as expected ovarian insufficiency or poor ovarian reserve. So unexpected group 1 and 2, and expected were group 3 and 4. And the options in front of us were to proceed with either our own gametes with some altered protocols, or to use donor cycles, or to tell them to adopt children. So these were something that we needed to understand. But more importantly, we are now looking at how should we halt or reverse premature ovarian aging or insufficiency, because basically we are also having this major problem of premature menopause. It's not just the fertility, but it's the life of the woman, which is so long now, and yet she's living without the required hormonal support. So, so then, oh God, चले गई मेरी place. 1 second. I'll have to.
We can see the slide.
You can see it. I can't. 1 minute. I'll just see it. Oh, what has happened to my screen? Yeah. So basically, what we need to understand here is that this diminished ovarian reserve is also progressive. It's not an overnight kind of a thing. It may be overnight, or it may be present right from birth in the kind of patients that Mala had talked to us about. But in majority, what is happening is this diminished ovarian reserve is taking some time to happen. And generally, of course, yes, we are finding it happening at very young age in India and in the patients who are coming to us. But the various stages, I would say, of this are also different. And you find that some of them are actually coming to us and they are compensated. That means they are fine. I shall talk about it. Then there is a stage of desynchronized cycle where the cycle is going haphazard. The ovary is not listening to the the pituitary ovarian axis. And then there is a stage of pathological premature LH surge. You are trying to do a cycle, and in between there is a LH surge and the whole cycle is destroyed. You have that kind of stage also, and you try your best. It keeps on happening again and again. And then finally, there is this stage of suppressed follicular growth where you do your best and yet you are not going to get any follicle. And this is the one which is where everything is lost, and you do have to offer them some kind of a donor cycle. So these are the 4 stages, and I'm thankful to Dr. Jatin Shah for lending me his slide, which actually explains it so well. So here is what you would find in the compensated stage. There is a low AMH, high FSH on day 2. The estradiol level on day 2 is normal, and the development of a mature follicle may happen, which is going to happen on time, and the cycle length is 26 days, slightly shortened. So ovarian reserve is actually there. It is reduced. It is reduced because you find that the AMH is low, but the endocrines are compensated and the mechanism is still working. That means this patient, if you are trying to do something for her, you will get some result because she is nearly all right. It may be a little low, the ovarian reserve, but it is all right. Her endocrines are normal. Then this is exactly what Shobha had asked me to say, whether these patients are eventually going to require some kind of a help or not. Yes, we will talk about it a little later. So let me take the first case. 30 years, she's a data analyst, she's unmarried, and she's come for fertility counseling. So what happens is she's unmarried. So cycles are regular and scanty, which is, of course, which we want to place her in that category. And it is just for a day or two. And of course, the cycle length is the same. There is no history of dysmenorrhea. Past history is also normal. And family history, there is early menopause in the mother. So the day 2 hormones were AMH is 0.9, which is definitely low. FSH is 10.63, again borderline, just on the brink. LH is 6.1, kind of all right. Estradiol is 35.7. Progesterone is 1 and prolactin is 22. TSH is also all right. So basically this hormonal profile is telling us that patient is okay. Yes, her ovarian reserve is definitely hit because AMH is low and FSH is also on the brink. It is the upper limit of normal, and therefore it's not 25. It's not 25. So we have a lot we can do for this patient, and so we counsel her about her falling ovarian reserve, and we tell her that she should get her oocytes cryopreserved, fertility preservation, with multiple oocyte collection cycles also being told to her because her AMH is low, and we think that we may not get enough oocytes in one cycle. Hence, we prepare her already to take multiple oocyte collection cycle. And so what we did was we down-regulated her. We gave her an agonist protocol. See, because her FSH is 10, we had to bring this down also. So you down-regulate her, give her an agonist protocol with HMG stimulation and an HCG trigger and a collection of 12 M2 oocytes over 2 cycles. The same were cryopreserved, and therefore we have done a good service for her because now her fertility is preserved. She can get married whenever she wants to, and she has these oocytes which she can use later on in life. So therefore, first step of her premature ovarian aging has been sorted. She has got a reserve, and now we have to tackle her whatever Shobha tells us in the prescription writing. Then you come to a second stage. That is the desynchronized cycle. Here, what is happening is that the patient has gone ahead a little bit in age as well as in that kind of cycle that she's having. So it is all asynchronous. Asynchronous. There is a low AMH. FSH is normal. It's still normal, but the E2 is high. So therefore, it is asynchronous. FSH. Why is the FSH low and the E2 is high? Low because the E2 is high. If the E2 is going to be high or the ovary is over responsive, then naturally the pituitary or the hypothalamus is not going to secrete that much of gonadotrophin, and therefore the FSH is going to be normal, but E2 is high, and there is a development of a mature follicle seen in one of the ovaries. Cycle length is again 26 millimeter. So this pathological follicle formation is actually from the luteal phase of the last cycle. That means because her cycles have shortened, she's picking up a premature follicle from the last cycle, and it is coming up and seen in this cycle, which is therefore going to make this cycle, the follicular phase of this cycle, shorter. Some of it has already happened in the luteal phase of the last cycle, and now some of it is going to happen in this cycle. So there is a dyssynchrony, and this follicle is going to interfere with the other follicles that you will try to make when you're doing her follicular stimulation. So in such a patient, you will find that one of the follicles is very big and the others are small, and therefore you will say, oh God, now what am I going to do? I'm not going to get enough eggs from this patient. So this is a dysynchronized cycle. So what do you do in this case? So here is a patient, I'll give you an example. 29 years, HR consultant, previous cycles are regular, 1 to 2 days again, scanty flow, but no history of dysmenorrhea. She's married for 6 years, trying for conception since marriage. She's had an ectopic in 2015, and she's also had a laparoscopic right salpingectomy. Now, when you look at her hormones, hormone is 1.02 nanogram, FSH is 9, absolutely okay, LH is 6, estradiol is 108, and progesterone is again normal, prolactin is normal, TSH is normal. Now, when you do an ultrasound on the same day that you have done the hormones, you find that there is a 16 millimeter clear cyst seen in one of the ovaries. This is something that you will also find when you're going to do an IUI cycle. You are wanting to start a cycle and then you see there is a huge cyst in one of the cycles. You want to abandon that cycle. Yes, because this is going to interfere with your patient. But now some of us, what do we do is we follow it. And when it ruptures, you do an IUI, you can still get away with a pregnancy because this follicle is from the last cycle if the patient is of an older age group. Remember, this is from the last cycle, and therefore, if you can use it, definitely you can use it and the patient may get pregnant. So therefore, physiology is changing and our management is also changing as we are learning more and more about these different types of patients. So what happened is she's already had ovulation induction and 2 IUI cycles. Husband is absolutely normal. And so what we did is we suppressed her again because her E2 was high. She had a cyst in one of the ovaries. So we suppressed her with agonist and then started an HFG cycle, gave her gonadotrophins. In 10 days, she formed good follicles, and we gave her a recombinant HCG trigger, retrieved just 3 oocytes, remember, because her reserve is poor. Embryos were formed and we did a day 3 fresh transfer, result was positive. So again, this patient tells us that, you shouldn't get disheartened when you find a dysynchronous or asynchronous growth, because these patients also are actually showing you some kind of a feature of premature ovarian aging. What about the premature LH rise? Here you find that when you are doing a stimulation, suddenly there is a rise in LH and everything is lost. How is it detected? See this case. So this is a case where she has primary infertility of 7 years, trying for a pregnancy, family history of hypothyroidism and hypertension, past treatment, multiple cycles of OI with oral ovulogens, etc. AMH is 0.8, FSH is 10, LH is 7.2, estradiol is 60, and progesterone is 1.2. Here again, you find a discrepancy. FSH is slightly high, and so also is the estradiol. So here you don't find any cyst in any of the ovaries, and you want to go ahead. So you start with 300 IU of the HMG every day, and you have beta band karo usko. and you find 4 follicles of size 10 and 9 on the first ultrasound on the 5th day of the stimulation. That means you've given 4 doses, and when you call her on the 5th day, you find that there are follicles growing. But when you see her on the 7th day, you find that there is an arrest of growth. This happens to you all also whenever you are doing an IUI cycle. In such patients, remember, suddenly you find that there is no growth, it has become static now. So in those cases, if you see the LH or if you do the LH, you will find that it is risen and it is beyond 10 MIU. So it is, in this patient, it was 17. We gave her a shot of antagonist immediately, increased the dose to 450 just to rescue this cycle. So follicular growth was seen in 12 days of stimulation. Everything came all right. A trigger was given at size 20 of the follicle. 3 oocytes of poor quality were retrieved. Very poor quality, day 3 embryos were formed. Fresh transfer was done, and the result was negative. We knew that it is going to be negative, but just because the patient had already spent so much of money, we thought we might get away with it, and therefore we kept on trying. And basically, this is what happened, that the embryo quality was poor and you did not get a good result. So this happens when there is a premature LH surge and you keep on, trying to retrieve it. And this is what happens very commonly in these patients of poor ovarian insufficiency. Suppressed follicular growth is something that you see all the time in your patients. And you find here that everything is low, and you find the FSH may be normal, but it is high also. Estradiol will be high. Again, there is haphazard growth in such patients. Here is a patient of 32 years who had the similar kind of picture. Cycles were getting shorter, but there was otherwise she had been married for 8 years and trying for a conception ever since that, and never was successful. So again, if you look at her hormones, look at her AMH, it was very, very low. FSH is normal. Estradiol is borderline high, not much, but everything else is normal. Ultrasound scan shows 2 to 3 AFCs only on each side. Uterus is normal. So what do you do in such a patient? IUI in this patient was done in 2017, and she had already done one cycle of IVF in 2018, where again they did get oocytes, but nothing happened. She had a negative test. So what we did was, in order to collect, now this is something that you all should know, this is called a duostim cycle, where we give 2 cycles back to back, one in the follicular phase and one in the luteal phase. You keep on giving stimulations in the same cycle, based on the premise that nowadays we know that there are at least 2 or 3 surges or waves of follicle formation in one cycle. So we started with a slightly higher dose of 375. In 8 days, she was ready. We gave a dual trigger HCG and agonist. Although in dual stimulation, you don't give HCG, but here we did give her HCG. We retrieved 2 oocytes because we were worried about the maturity of the eggs. So hence we gave this. Embryos were formed, and then again we started stimulation after 4 days of gap. Again, 4 oocytes were retrieved after 10 days of stimulation. Then we got 3 grade A embryos, very nice, 10 cell. We took them to blastocyst formation, and then we had 3 blastocysts which we froze. FET was done after 2 months with HRT protocol, and she turned out to be positive. So here the difference in this cycle management was, knowing that she is having a poor ovarian reserve, we tried to accumulate the number of eggs and the number of embryos, and then pooled them together and started transferring them. And therefore, we got a better result than what they got in the first cycle. So these are the various combinations that we have to try in these patients. Again, another patient which is 42 years of age now, having very bad reserve. And you can see over here, hormone was just 0.05, FSH was 8, LH was 4, estradiol was 27. Everything was there suppressed, but and ultrasound showed right-sided hydrosalpinx in addition to no OAFC or 1 or 2 AFC each cycle. Now, in such a patient who's already 42 years of age, we suggested that basically we will do minimal stimulation with no stimulation, just a modified natural cycle. We let her be, since we wanted to see whether she's forming an egg or not, which she did. And then we basically did not give her any gonadotrophin, just gave her a trigger on the day that the egg was mature or the follicle was seemingly mature. That was 13 days later. So therefore, we gave a recombinant HCG, and one oocyte was retrieved which did not form any embryo. So remember, in these patients, even if we get eggs, they may not be of good quality because they don't have a good reserve. And these patients, it's not just they are genetically abnormal eggs, they may also be morphologically abnormal. So you have to be very careful in how you counsel these patients of premature ovarian insufficiency. So the patient was counseled donor eggs right from the start of the cycle. A donor was stimulated simultaneously, and a day 3 fresh embryo transfer was done using a donor egg of this in the same cycle. The two embryos were transferred, and the result was positive. So in this patient, she is Poseidon type 4, wherein she is more than 35 years of age, and her parameters, her ovarian reserve tests are all showing that she has hardly any reserve, and that is how she behaved. One egg, which did not result in a pregnancy, and eventually we had to give her donor eggs. So therefore, how to address this challenge of premature ovarian insufficiency in these patients who are so desirous of children? In the unexpected poor response, you can do some kind of a jugglery with various different altered protocols. You can continue giving them some kind of embryos wherein you will get pregnancy. You have to change your dosage. You have to look at every aspect of the stimulation, and you will get response. In group 3 and 4, these are the difficult ones, especially the group 4, where there's nothing in her. Her ovarian reserve tests are poor and her age is against her. So the best thing is to offer her donor gametes or adoption in such cases. Now, if you have to, this is in the expected poor response patients. Uh, what is Shobha? Do I have time? Can I go on, or should I stop here? The other thing is to reverse or halt the premature ovarian insufficiency, and for which we have non-surgical methods and the surgical methods. We have certain salt.
Ma'am, you have another 2 to 3 minutes, ma'am. You can
Oh,
complete.
3 minutes. I'll complete it in 3. So xenotherapy is the name given to those methods or those drugs or nutraceuticals which are used now to delay or reverse infertility or reverse the aging process. And this is a huge list of these agents which we are using now. Most of these we are using. Rapamycin and NAD precursors we are not, but Resveratrol is now majorly being used, melatonin is being used, coenzyme Q10 is used, and NAC is being used. So we are using all this. These have been tried very efficaciously in animals, but there are mixed reports in human beings. But I'm sure with adding evidence, these are also going to come up. And this is not just for fertility; this is also for the aging woman. So fertility preservation, I did describe to you in one of the cases, oocyte freezing if she's unmarried, sperm freezing if the man is unmarried, and embryo freezing if they are married. You can offer this to them in order to circumvent this problem of fertility. So, what are the new strategies for prolonging the reproductive potential? That is ovarian rejuvenation by PRP and bone marrow stem cells, ovarian oocyte cryopreservation, ovarian tissue cryopreservation, ovarian activation. This is something that you should look at carefully, and artificial ovary formation. So, there are so many things happening now which are actually there to help the patient become a little younger, as Ragini would want her to be. With her cosmetology and aesthetics. So ovarian rejuvenation with PRP is something which has become a household name. You know, PRP everybody does for everything: skin, hair, bone, etc., etc. We are also using it for the ovaries as well as for the uterus, where the endometrium is thin, and it is your own plasma. It is autologous. It is basically injected into the ovary. Now, the pros and cons is there is no standardization and methodology for making the PRP, no set protocol for timing the injection, no protocol for frequency and numbers of PRP, and no protocol for assessing its results. So essentially, it is in its nascent stage, and we still have to look ahead for the kind of evidence that may get generated out of the way we are using it. But of course, it has no harm. It has no side effects. PRP actually is an antimicrobial agent, and therefore it is not going to lead to some kind of infection over there. It is not mutagenic, and therefore we are safe that it is not going to lead to cancers also. So these are some of the favorable things, but yes, lots needs to be done. Stem cell therapy, autologous bone marrow stem cell, umbilical cord stem cell, adipose tissue stem cells, menstrual blood stem cells. These are the various areas from where we are deriving them. And we all know that we are basically doing autologous bone marrow stem cell in our branch of science. So all of this also releases growth factors, and these all they promote cell proliferation and angiogenesis, and therefore they decrease inflammation and hence help in formation of new cells. So that is how it helps. This was a very exciting development that took place a couple of years ago, where they used the ovarian follicular pool to postpone menopause and delay osteoporosis. So what happened was they stimulated the ovary, took out the isolated follicles, and then covered them with some kind of a cover.
Please mute. Please mute.
Please, can we mute? Excuse me,
Please mute कर दो आप.
म्यूट करिए, परेश जी म्यूट करिए.
लाइट्स है क्योंकि रात को जलती है. अरे दिया,
Oh my
I
goodness.
don't know. All right guys, अपने में
अरे भैया कौन हो?
दिया तो
कुछ और मत करने लगना.
So anyway, this was they used as kind of a cover over the follicle so that they are not destroyed, and they kept them frozen. When it was to be when they wanted it to be transferred, they took them out and grew them artificially and then put them back. So this is a very good method which everybody is thinking will help many women postpone their menopause, because they have got these eggs preserved over there which will grow and give rise to hormone formation. So this is from the ovarian tissue. This was transplant. Now, ovarian activation is a method which is becoming very popular. What is done is that on laparoscopy, the part of the ovary is removed, the cortex, and from there you take out small fragments which are actually put in culture for 24 hours, and then on a second laparoscopy, it is put into the ovarian fossa, and where these cells start to grow, and finally ICSI is done on the follicles, just as we do after stimulation. After stimulation, you remove the follicle as you remove in IVF, and then do an ICSI for them. So this is a method wherein the ovarian activation is done outside inside the lab. Now, what the other method, which is a shortcut, because here there are two stages, one laparoscopy and the next day again a laparoscopy. So they do a drug-free IVI wherein a laparoscope is inserted. You take out the cortex from the ovary, do the fragmentation, keep it for some time, 3-4 hours to incubate in the culture medium, and then put it back into the graft again. And because of the blood supply being maintained, it starts to grow, the follicles form, and finally you can do an ICSI with it. So this is a very promising technique which is being practiced by Dr. Jilla from Aurangabad. She has actually published this paper where she is doing this OFA, or ovarian fragmentation for follicular activation, along with PRP. So she takes a graft, she takes it, and then she takes it out, grows it, puts it back in the fossa, and at the same time she injects PRP also, and she says that this is giving her much better results in the formation of follicles and much better pregnancy rate as well. After cancer remission, patients do come back for treatment, and in these patients, ovarian tissue cryopreservation is being done. And what is done is similarly, like I explained earlier, the cells are taken out, they are incubated in the culture medium, but they are covered by some kind of a capsule, which is a 3D matrix, and therefore, so that they are not harmed in any way, they are kept after washing, cleaning them. This is actually cryopreserved. And then once the patient comes back for treatment after cancer remission, the cells are taken out, it is thawed and then grown in the laboratory to form new oocytes and put back into the woman. So fertility treatment plan for patients in POI, to end my talk, is basically depending upon whether she is possible of having a natural conception or not. She's young. So in such patients, you can offer them ovulation can occur in up to 25%. Pregnancies may occur in 1.5 to 10% again. So we should tell them not to, delay their efforts at trying for a pregnancy, keep on doing it, and of course, contraception if they do not want a pregnancy. Fertility interventions, I've already told you, ovulation induction, oocyte donation, and future oocyte autotransplantation of oogonial stem cells, like I described. In patients who are at risk for POI, you must identify that risk. oocyte cryopreservation must be offered to them. Ovarian tissue cryopreservation also should be offered, although it is experimental, but then it is needed for the prepubertal cancer patients. We have to do it for such patients. Then surgical transposition of ovaries before pelvic radiotherapy is also one good method, and GnRH analogs during chemotherapy also to protect the ovaries. So with this, basically we have lots to do now for patients who are getting older or showing signs of premature ovarian aging, where you have to tell them of all these interventions which are available now, so that they can either have children that they so desire, and if they don't desire children, at least they may be protected from the harms of premature menopause. So with that, I thank you all very much, and thank you for being here with me. I hope I have justified what I was asked to speak on, Shobha. Thank you very much.
Oh, beautiful, madam.
As
My
usual.
goodness.
Thank you.
As
Yeah.
usual.
Thank
Oh,
you,
That was
madam. It was
fantastic. That
superb.
was fantastic. Yeah.
hi, Maninder.
That was really, really exhaustive. And I think you opened doors and windows, so much of futuristic thoughts. And much of it is also happening. That is what is so much exciting about it, ma'am. You
And it's
said that there is a
happening in India.
publication on ovarian activation,
Yes, and there
and
is
women are
another one.
already benefiting.
There is another one from Nalini also. She did it
Mhm.
in a case of endometriosis, but of course she did not get pregnant, but she started menstruating. So,
Yeah, but
women are
that is a
trying.
big achievement.
Yeah, it's very big. Yes.
Very big achievement. Hats off to this technology and to the
Absolutely.
scientific innovation which has allowed women to benefit. And
Technology is growing at a very, very fast pace. We are not able to keep pace with the technology.
exactly, Maninder, you're right. I think with everyone's permission, let me just share my screen and finish what I wanted to say.
Thank you.
And then and then some discussion can come forth at the end of it, so that we are not out of. Oh, why am I not able to share? Okay, one moment. Mhm. Okay. अ, परेश जी क्या डिफिकल्टी क्या है इसमें शेयर में
हम ये कर सकते हो ना, आप शेयर स्क्रीन करिए ना।
शेयर किया अभी इसमें स्क्रीन है डॉक्यूमेंट है और एडवांस्ड कुछ ऐसा आ रहा है मेरे लिए I recently changed my but I was able to share the other day
या यू कैन स्क्रीन वाले में ही जाइए और वो विंडोज शेयर करिए ना जो
हाँ
ओपन
ठीक है देखती हूँ I have actually opened my presentation here but it is not seen in the screen
नो यू हैव टू एग्जिट फ्रॉम स्लाइड शो मोड।
हाँ नहीं I am not in slideshow mode why am I not able to share this is very strange just a moment डॉक्यूमेंट्स में आएगा क्या नहीं ना
इसमें नहीं, स्क्रीन पे ही आएगा, पहला ऑप्शन ही, फर्स्ट ऑप्शन ही।
entire screen and application windows but in application windows it is not showing up okay it's
डॉक्यूमेंट
asking
वापस
me
ओपन करिए,
one
इनिशियल
minute
जो फर्स्ट स्क्रीन है वही ओपन करिए।
1 minute this is very sad
किस बात की शांति छा गई इतनी?
Is my presentation seen now? Is my screen visible?
स्क्रीन दिख रही है, कुछ पेड़
Visible?
दिख रहे हैं, कुछ आपका आधे में प्रेजेंटेशन और आधे में स्क्रीन
हाँ, मैं कर लेती हूँ उसको.
कर
अभी
लीजिए.
ठीक है?
यस
Yes,
यस
yes,
Yeah, yeah.
it's
Am I
fine.
audible also?
यस.
Yes, you're audible, ma'am.
Yeah, I'll be quick. Yeah.
बस आप भी
So
कम
I
करो.
think I have a simpler task now that two of our very experienced clinicians have spoken. But then, just to reiterate, this will be the common diagnostic feature for POI, which is a very broad term, and then premature menopause, which is a bit more specific to us as women attaining failure before 40 years of age instead of between 40 and 55, and they become symptomatic oligoamenorrhea for at least 4 months with an elevated FSH on at least two occasions. It's written more than 40, but I would consider even more than 30 as diagnostic, at least 4 weeks apart, as Mala already said. So, whenever we encounter women like this within 40 years, because this is IMS platform, so maybe we should stick to the older women in the beginning at least, less than 40 years, irregular periods, negative serum HCG, that means no pregnancy, may be symptoms of hot flashes, which may be intermittent, at times no hot flashes, promptly measure the TSH, prolactin, FSH, and even E2. Sometimes even E2 is required if patient, you know, day 3 of a cycle FSH can be taken in women who are having period. That may be better. But otherwise, all other hormones can be drawn on any day. Are TSH and prolactin normal is the next question. If the TSH and prolactin are normal, yes, they are normal. Then what are the FSH and A2 levels is relevant. And if it is low normal FSH, low or normal estradiol, that means normal FSH, normal E2, then you have to think about hypogonadotropic hypogonadism. Okay. If suspicion for POI still remains high with hot flashes, if low suspicion, then just monitor them. Just monitor them. So we must start thinking about hypogonadotropic hypogonadism if the levels of are normal or low. That means a central cause for low hormones, which may be autoimmune or maybe some other cause. But if there is a high FSH or a low or normal E2. So please remember the estradiol may not always be low, it may be normal also. And this is the group of women which we have been discussing today and which we are expected to treat with menopause hormone therapy. Likely diagnosis is POI. So you repeat the FSH and E2 in 1 month for confirmation. But in the presence of symptom, even this much is enough for us to begin treatment. So even though you may want to repeat it after 1 month to establish the diagnosis, I don't think we will be challenged if in the presence of hot flashes we can begin the treatment. So high FSH and higher E2, if it is there, possibilities may be that it is a false positive high FSH, it's a mid-cycle surge, or maybe we are looking at a tumor, a pituitary adenoma in the premenopausal patient, which is very rare. Okay, so therefore, we may not consider it here. It is a rare thing. Now, if the TSH and prolactin are not normal, then it becomes easier for us because then we can explore thyroid disease and we can explore hyperprolactinemia. We can take endocrine opinion and we can go ahead from there. So this is a very useful flow chart for evaluation in the menopause clinic because if the woman walks in with this, then we can do these 4 hormones and in the next visit we can sort out what we need to do. So that is possible. The management of women with spontaneous POI begins with information. We have to inform them in a very sensitive and caring manner, give them accurate information about the diagnosis. And then it's very important to build up the team. That means refer women with conditions to appropriate resources. Even for emotional support, we may have to have a separate healthcare provider who can give them more counseling on the psychological aspect or emotional or the social aspect. Estrogen therapy is a must for them unless there is an absolute contraindication. The 4 or 5 that we know is an active liver disease or gallbladder disease, a very severe case of migraine, or a known cardiovascular disease, hypertension, especially, or IHD, or a known breast cancer, or known venous thromboembolism, or known arterial thrombosis. If these conditions are not there, it is very safe to start estradiol therapy for women with a grade 2C recommendation, which is a rather higher grade, to reduce the risk of osteoporosis, cardiovascular disease, and urogenital atrophy, and to maintain sexual health and quality of life. So I think there are far more, benefits than risks. These are all major problems which affect the quality of life in a very big way, especially because the lifespan of women has increased, and especially because the quality of life that they aspire as they grow older has become higher and higher. A progestin needs to be added for those with an intact uterus. Now, estrogen progesterone contraception, can they be given to these women? Now, they can be given in women who especially want to avoid pregnancy, because please remember, occasional ovulation can happen in women who apparently present as POI, and a very, kind of nasty scenario of an unwanted pregnancy at an older age can come up. And therefore, if they desire contraception, combined oral contraceptive pills, I must reiterate here, the low dose COC can be prescribed as an alternative, at least for a short time, and the response can be taken. How long should we give? We all know that it should be at least till the natural age of menopause, which may be 50, 51 years, and we can follow the same for Indian women also, though our average age of menopause is slightly less, but this works for us up to 50 years, and this is a grade 2C recommendation. Now, in women who have a family history of breast cancer, in them, we can stop hormone replacement therapy at the age of 45 years. And I think that will make sense. In women with infertility, I need not go into this because Madam has already spoken so well on this. But there is grade 2C recommendation that it is not worthwhile giving them much of ovulation induction, rather IVF with donor oocytes or donor embryos in the women who really deserve this will give a higher success rate. And I must say that it is a lot less stress also to the family and the couple if provided in the strictest of confidence. Donor gametes, etc., or the donor system can give less stress to the couple because they know that chances of success are more. Otherwise, the treatment itself becomes very stressful when we try inducing ovulation for them. Now, in women who are identified with POI, they may not be hypothyroid when recruited, but they are at risk of developing autoimmune hypothyroidism and even other autoimmune problems, and they should have an annual checkup for that. In women who have autoimmune oophoreitis as a possible diagnosis, women with positive adrenal antibodies but normal adrenal function at the initial evaluation, okay, should be retested annually and should be retested with an annual 8 a.m. serum cortisol level. Now, this is important to know, though we may not be doing this. It is important to know that whenever we suspect an autoimmune oophoreitis as a cause, they may have, as Mala very clearly pointed out, that adrenal and ovaries might get affected by autoimmune disorders simultaneously, and therefore we'll have to take full help and supplement of serum cortisol, oral cortisol if necessary, will bring out the best of results in addition to our hormone replacement therapy. These women may also have skin pigmentation, more fatigue, orthostatic hypertension, etc. Now, this is about the pubertal induction in women who are girls who are having Turner syndrome. I thought these are standard therapy charts. So, in addition to what Dr. Mala had spoken, actually, we need to start very early in them. And we need to start with, if you speak about conjugated estrogen, then you can start with 3 and increase to 6.25 microgram like that. And we can start the progesterone once they start having the withdrawal bleeding. They have to, the pubertal induction may take anywhere between 1 to 2 years and even to 2.5 to 3 years. And we may have to give progestins for 12 days every month going forward. Okay, that the dosage we can discuss later. a little going forward. The doses are not very different, except that we start very low dose in these young girls and we build it up to 37.5 and 75 and 100 microgram of progesterone as we go ahead. So initially we can start with a 37.5 microgram per day estrogen patch and then increase it gradually to 75 microgram by the time they are 15 years of age, and then increase to 100 microgram estrogen patch if it is available later on. Similarly, oral estradiol can be, if transdermal is not available for us, oral estradiol can be started 0.25 milligram daily, gradually advance to the full adult dose of 2 milligram per daily. So this may take 6 months to 1 year on each titration of the dose. So we can give this for 1 year and then, or 6 months, and then escalate it to the next. And we must monitor them for the induction of puberty and menarche, and then add the progestin at least for 10 days at the beginning of every cycle when they start menstruating. Oral ethinyl estradiol at 2 microgram per day. I still remember earlier we used to have a drug called Linoral, which was oral ethinyl estradiol, and it used to be 2 microgram, very, very small dose. And it can be increased up to 5 tablets per day, like 10 microgram per day. Transdermal estradiol, I have spoken of, beginning 0.25 and then increasing to 1 milligram per day. All right, so this is the pattern of MHT which we can follow in a girl with Turner syndrome, and it can last for a few years and then it can attain the full adult dose by the time she is 18 or 19. And we have to check her out every 3 to 6 months. And then as she is closer to puberty, we can have after she has attained puberty, we can have an annual checkup for her. So these kinds of charts are very easily available. This is an excerpt from Up to Date, and we can have these kind of guidance charts for management of Turner's syndrome, and we can check them up annually and look at their growth and their secondary sex characters coming up and their skeletal system development. And we can look at encourage their lifestyle and as other speakers have already said, that we must encourage them to become to have some vocational training or a good education and become financially independent, because we are not certain about their reproductive and social standing later on. So then we can also have their other endocrine systems checked up, and even liver function testing for diabetes, etc., should go on, because sometimes autoimmune problems can manifest with diabetes also. Um, Cardiovascular system and her ultrasound can be performed to assist with HRT. So sometimes we do their uterine ultrasound and their DEXA scans, so as going forward as she becomes older, just to guide, as a guide for the HRT, as a guide for the HRT. So we have to have a very elaborate plan. Undoubtedly, if we are handling the hormones, she should be with an endocrinologist for the rest of her care. And sexual health and sexual well-being will be our responsibility. We have to guide them for that. And then there is contraception and preconception counseling also, whenever there is a clinical indication for this. So we need to give a very, very kind of intense program for a Turner's girl. And I think today they do have a complete life as a woman, just like others. If we take the hormone therapy, if we execute it well, they do develop into very fulfilling young women. Now, when we have menopause prior to the age 40, the data, these are very old data, but they show that whenever we treat them, they really do well. There is very good guidance from ESHRE in 2015 and also the recent guideline that we need to treat them with MHT very vigorously. The etiology has been discussed, so I will not go into this slide. It has already been discussed. Rather, I will take this case, who is a 37-year-old, actually a lecturer and has completed family, but had a history of difficulty in conceiving earlier. And now she has become amenorrheic. She has moderate to severe vasomotor symptoms already, 5 months of amenorrhea. She is having bad mood swings also, feeling very low. And since she became a mother at a later age, her children are still young and she has a very poor quality of life. She wants her life back on track. FSH is 47, repeat after 6 weeks is 51, so it is remaining high, and we have a diagnosis of POI. So in this girl, we know that this woman, reduced fertility, she may not care much about, but poor quality of life is already there for her. Every day is a misery, every night is a challenge. We know that she has a reduced BMD already, maybe, but we also know that if we don't do anything about it, she will have an increased fracture risk as she grows older. She has increased cardiovascular risk without doubt. She is going to have genitourinary symptoms and increased all cause mortality without doubt. So, therefore, we need to get into the MHT, vasomotor symptom. These are the indications. Genitourinary, yes. Bone health, yes. Cardiovascular. So, in women who are less than 40 years, these are the predominant reasons why we should start them on menopause hormone therapy and continue till the average age of natural menopause. So there is a very, very strong case for giving them menopause hormone therapy. It will also work towards normalizing sexual function, and glucagon estrogen also should be prescribed very liberally, because these are women in the prime of their sexual activity, and dyspareunia is going to mar their married life very badly, and therefore we must treat the dyspareunia and hormone insufficiency. uh, the case is further stronger because in this in this woman, particular women, and the cancer breast risk is going to be low. If we give MHT, the risk of all these is going to be less, and the symptoms are already moderate to severe. We need to give her adequate estrogen and continue treatment till the age of natural menopause. Having said this, we need to have certain nuances of finer treatment for them. Is it going to be the same as postmenopausal women? So let us look at some of the differences which might be there, because the line is very fine and it is going to be our clinical judgment. The role of hormone therapy is to manage deficiency symptom, prevent long-term health risk associated with POI, and which is predominantly osteoporosis, coronary heart disease, and stroke. So let us not fool ourselves that, if we don't give hormones and if there is a good lifestyle, women will be safe. No, MST is necessary to prevent these problems, and let us believe that very strongly. It will, of course, improve QOL and maintain sexual function. Okay. Now, unless there is an absolute contraindication, all women of POI should receive estrogen therapy to reduce these risks. Suggested estrogen regimes. Now, in younger girls, in whom secondary sex characters have not developed, they are given very low dose of estradiol because the tissues are so sensitive at that time. This we have already discussed. In women who present like this with secondary amenorrhea, we initiate full replacement doses with oral estradiol 2 milligram per day, oral estradiol 2 milligram per day, or transdermal 100 microgram patch. An estradiol vaginal ring if you are using 100 microgram daily. This dose is higher than what is used for postmenopausal and is based upon average daily production of estradiol by the premenopausal ovary. So please remember, we need higher doses in these women. Transdermal or vaginal delivery of estradiol have advantages over oral, including lower risk of venous thromboembolism and gallbladder disease. For women with symptoms suggestive of genitourinary symptoms, so be very, very proactive in finding out the symptoms of genitourinary syndrome of menopause. Vaginal dryness, urinary symptoms should not be overdiagnosing UTI and giving them antibiotics. Think about her total spectrum of problem and quickly implement low dose vaginal estrogen. So we need to be having a lot of high, a very low threshold for giving them the prescriptions. And the choice of progestin, most of them will be having an intact uterus because they are not come to us with bleeding problems. They will not have their uterus removed. They will have intact uterus. So how to protect the uterus and prevent cancer? First line progestin is micronized progesterone. Now this can be used 200 milligram per day. First 12 days of month is what is recommended in amenorrheic women because it is easier for them to remember. because she is taking a continuous combined. If she wants periods, then you can give her sequential, and in the sense continuous combined, and she can be have a break for a period in between. But then the symptom relief is much better when we give them continuous, and we replace micronized progesterone. We add micronized progesterone first 12 days of the month. This can be even combined with LNG-IUS if women prefer that over oral progesterone. There are no good data about which progesterone is best, and all the studies which show that micronized progesterone is better than LNG-IUS for protection of endometrium are actually quite heterogeneous, so I shall not comment on that. For women who desire treatment for symptoms but want to maintain the possibility of a spontaneous conception, there always will be women who will tell you that if pregnancy accidentally happens, she would love it. I'm so sorry. She would just love it. And therefore, in such women, we can use micronized progesterone instead of LNG-IUS. Now, there are other advantages of MP over the medroxyprogesterone acetate, which was used, still being used by some practitioners, that there are no adverse effect on lipids or clotting factors, but definitely not been studied in POI population. But whatever it is, micronized progesterone, we have become very familiar with that medicine, and I think we will prescribe that over medroxyprogesterone. Without being too emphatic, it goes without saying that exercise, healthy diet, adequate calcium, vitamin D, avoidance of smoking and alcohol, they are integral part of the management, but often understated. So we must be very emphatic about it. A word about COC as an alternative option. I've already spoken about it, but then it does contain ethynyl estradiol and progestin. It has the added advantage of providing contraception, but physiological hormone therapy may be more beneficial for bone mineral density than higher dose estrogen. This is what research has shown, that though we say that COC builds up bones, the MHD prescriptions which we give, the estrogen compounds which we give for MHD, they are healthier for maintaining the bone mineral density than a combined oral contraceptive. I think this is what I wanted to bring forth today. And with that, I will end my presentation, and I will ask for questions, because I think some may be wanting to ask questions to Sonia Madam also. Thank you.
Thank you very much, Shobha. It was a really very awesome presentation. You covered the whole topic. So I think today's webinar was excellent. All three speakers didn't leave a single stone unturned, covered all the details and given a lot of carry home crisp message to all. Paresh,
कविता जी म्यूट कर लीजिए. Yeah, I think she muted. Yeah.
Yeah.
Any questions? One question was there, turners should be managed by whom? So I have written endocrine or and Sonia Madam has said that she had to leave. Now, which adrenal antibodies should be tested? I think Dr. Mala had spoken of it, and we must really be very specific about what we are expecting. Which adrenal antibodies? There will be autoimmune, whenever there is an infection, we need to test, accordingly. We have to consult the endocrinologist and then ask. For autoimmune oophorytis, I think it's just a clinical suspicion. I don't think there is any antibody described for that. How is it diagnosed? It is a clinical suspicion, autoimmune oophorytis. Whenever there is a change in the menstrual pattern, and then we have to see whether there is any spectrum of any other autoimmune problems, especially autoimmune thyroiditis may be associated for them. Okay, so we need to look at the whole spectrum. Specific antibodies, I don't think are outlined. Yeah, I think that is about the questions. Yeah. Sonia madam has left actually, so I think we have done some justice, and we have.
Not full justice.
Oh, thank you, thank you.
Yeah.
But always more can be done actually. So we hope. Actually, I'm missing our Sudha madam, because always Dr. Sudha has something to say at the end.
Sudha has to go to attend some other.
Okay.
So she told me that she after a few time.
Yeah.
And
Okay.
Ragini is also not feeling well, so she is also.
Yeah, I could make out. So I think with that, it is safe to end today's session.
So
Thank you. I
Vedic
thank you, and I thank Ragini. Thank you, Anita, for giving me the opportunity. And I thank the audience for joining.